Okay. So what are the clinical features of infectious mononucleosis? What are the clinical features of infectious mononucleosis? Now, this is also another place that I want you to pay attention to. What are the features which are most common and what are the features which are least common? For many of us, we know that infectious mononucleosis will present with throat pain, lymphadenopathy, and maybe some fever. But then, especially because I want to make reference again of the nature of the exam, which is about to change. Remember that a patient with infectious mononucleosis can have malaise, they can have fatigue, they can have sweats, they can have sore throat and dysphagia, they can have anorexia, they can have nausea, they can have headaches, chills, cough, myalgia, that is body pains, right? Ocular muscle pain, that is eye pain, chest pain, arthralgia, and then they can also have photophobia. However, if I bring you a stem and I say that which of the following are more common features of infectious mononucleosis, you should be listing the things which are up here, or you should be looking for the things which are up there. So doctors, please, one take-home point is this. You must know the features which are most common and those which are less common. So I'll write it down. The features which are most common and those ones which are less common. So far as infectious mononucleosis is concerned. While I'm learning, that's something I want to pay attention to. What features are most common? What features are less common? And in the mock, we'll be quizzing you on that. So please, make sure that you've mastered this as well. Now, since we talked about symptoms, now we're going to talk about signs. Which signs are most common? In fact, some literature say that adenopathy can be found in almost everybody who presents with infectious mononucleosis. Okay, so adenopathy, fever. So the most common ones are adenopathy, fever, pharyngitis, splenomegaly. And then how common the signs are start decreasing as you go down this list. So adenopathy is very common, fever is very common, pharyngitis, splenomegaly, bradycardia, periorbital edema, and then it goes down and down and down. Palatal enanthem, liver and spleen tenderness, hepatomegaly, that's an enlarged liver, rhinitis, that is runny nose, jaundice. So never say that, oh, I only know that infectious mononucleosis, the common things are sore throat and lymphadenopathy. And then if you see jaundice, you go like, this is not a feature of infectious mononucleosis. No, jaundice is even a feature of infectious mononucleosis. Skin rash is also a feature, and pneumonitis is also a feature. Doctors, please pay attention to this table very well. Please. Right? Make sure that you're paying attention to this table. Okay, so now, one other thing I need you to do is that while you are learning these features, you also have to learn which features are more common in patients who are less than 35 years and patients who are above 40 years. Please, this is very important. I'm going to give you a question right after this. Which features of infectious mononucleosis are more common in younger people? Which features are more common in older people? Let's take our time. In younger people, the more common features are lymphadenopathy. Number 2, sore throat, that is pharyngitis. Number 3, enlarged spleen. In young people, the features which are more common, doctors, please write this down, because we are going to deal with a question right after this slide. Number 1, lymphadenopathy, young people. Number 2, pharyngitis, young people. Number 3, splenomegaly, young people. Okay, so which features are more common in older people? Number 1, fever. Number 2, hepatomegaly. Number 3, rash. Number 4, jaundice. Let me say it again. Younger people, which features are more common? Older people, which features are more common? Older people, fever, hepatomegaly, skin rash, jaundice. Younger people, which features are more common? Lymphadenopathy, pharyngitis, and splenomegaly. All right, good. Now, I have this question. because I promised you that I was going to drop a question. So please, I need somebody to read this for us.
A 30 years old patient present with fever, sore throat, and palpable lymph nodes. Which of the following clinical feature is most likely to be present in this patient based on age-specific data?
Beautiful.
A. Hepatomegaly. B. Rash. C. Jaundice. D. Splenomegaly.
Please type in your
The
answer.
answer is D.
D, most likely. So he's saying that jaundice is less likely, rash is less likely, hepatomegaly is
Oh,
less
less
likely.
likely. Less likely.
No,
Okay,
I'm
okay.
saying most likely. I'm saying most likely. What is most
Most
likely in
likely
a patient who is 30 years old?
splenomegaly.
Okay,
D.
sure. Beautiful. Beautiful. So, Dr. Khadija, you are paying attention. So, splenomegaly is more commonly observed in patients less than 35 years old. So, hepatomegaly, rash, and jaundice, you see it in patients who are more than 40 years of age. And this is very critical. You've got to know this. Okay, another question. Who will read for us again, please?
Me.
Mhm. Please read.
45-year-old patient present with fever and sore throat. Which of the following clinical feature is less likely to be present in these patients based on age-specific data? A. Lymphadenopathy. B. Pharyngitis. C. Jaundice. D. Hepatomegaly.
Mhm. Remember, less likely in a patient who is 45.
Lymphadenopathy.
So now we are getting the concepts right. So lymphadenopathy is less commonly observed in patients aged more than 40 years with infectious mononucleosis. Okay. So less likely observed. So lymphadenopathy is common in the younger ones. Okay. So clinical features of infectious mononucleosis, we've already talked about it: fever, pharyngitis. We mentioned 5 things. Lymphocytosis, right? So lymphadenopathy in all patients, even though it is less likely in those who are above 40, 45, you will still see the lymphadenopathy. Even though it is less likely, does not mean it will not appear. Now, if you want to pick up a case of infectious mononucleosis, look out in the questions term if it is describing, the fact that the lymphadenopathy is symmetrical, both sides, symmetrical. Number 3, the lymphadenopathy in infectious mononucleosis gets worse in the first week, and then gradually it improves over 2 to 3 weeks. So if the thing tells you that, oh, the lymphadenopathy started about 2 weeks ago and it seems to be improving, you are getting the point. Now, where is it more common? Even though we're talking about lymphadenopathy, cervical lymphadenopathy, it is more common in the posterior cervical and posterior auricular. There can be anterior cervical lymph nodes and everything, but where you see the most is the posterior cervical behind it, and then posterior auricular behind the ear. Doctors, please, can I move on? Posterior auricular and then posterior cervical. Okay, good. Now, there are people who may present with features of infectious mononucleosis, but they will have negative monospot test. So this draws your attention to differential diagnosis of infectious mononucleosis. So we call them heterophil negative infectious mononucleosis. And the causes of heterophil negative infectious mononucleosis, this one you must know it by heart. Number 1, you will see that I'll repeat it over and over and over and over and over and over again in the class. Cytomegalovirus. So you have a patient who presents with sore throat, lymphadenopathy, malaise, fever, but then the monospot test is negative. What are your differentials? My differentials will be cytomegalovirus, number 1. Number 2, HIV. Number 3, toxoplasmosis. Number 4, human herpes type 6. Number 5, human herpes virus type 7. So which group of conditions, or which condition can the patient have sore throat, fever, lymphadenopathy, malaise, but then monospot test or heterophil test is negative, please, they are cytomegalovirus. Write it down. Because the objective was saying you must know the differences. Cytomegalovirus, acute HIV in the acute stages, toxoplasmosis, herpes, human herpes type 6, and human herpes virus type 7. Doctors, please, is this okay for you? I don't want to feed you with too much information. I don't want us to get into unnecessary stuff. But these ones you must know. Sore throat, so causes of sore throat without monospot test being positive, HIV, cytomegalovirus, toxoplasmosis, human herpes virus type 6, human herpes virus type 7. This one, if you're even asleep and I come waking you up, you should be able to recite them for me. Negative heterophil causes of sore throat. Please, can I move on? Doctors, can I move on?
Yes.
Okay, good. So you must be able to tell me, patient presents with sore throat, fever, malaise, but monospot test is negative. What are your differentials? Good. Now, splenomegaly in infectious mononucleosis. This is also a very important thing you need to know. Splenic rupture is rare. And if it happens, it can be life-threatening. But how will you be able to pick up the fact that this patient has developed splenic rupture in somebody with sore throat? You will either be told the patient has abdominal pain, or you'll be given abdominal pain and then you'll be given lab results. And the lab results, you realize that the patient's hemoglobin and hematocrit is decreasing. Two things. The patient has sore throat. Okay, I know the differentials of sore throat. It could be strep throat, it could be infectious mononucleosis, it could be HIV, it could be cytomegalovirus, it could also be what? Human herpes virus type 6, human herpes virus, right? Okay, yes. Or toxoplasmosis. Now, I'll go further and tell you, oh, when we did the monospot test, it was positive. So if the monospot test is positive, then it is not HIV, then it is not cytomegalovirus, then it is not toxoplasmosis. But then I've gone to further tell that the patient has abdominal pain and the hematocrit is critically low. Sore throat plus abdominal pain plus low hematocrit. What should be my diagnosis, please? Doctor, shout it to me. What should be my diagnosis? Sore throat.
Splenomegaly with ruptured one.
Splenic rupture. Now, you know, there's this thought amongst us as doctors that the splenic rupture from infectious mononucleosis is most of the time due to contact sports. But let me tell you something. Should there always be contact sports in a patient with infectious mononucleosis for them to have splenic rupture? No. So if you have a case of patient with abdominal sore throat, abdominal pain, low hematocrit, and then they say the patient has not been in any sports game, that should not dissuade you from saying this patient has splenic rupture. Some patients, about 50% of patients with splenic rupture and infectious mononucleosis, the spleen ruptured spontaneously. About 50% of them. It can rupture spontaneously. So you should not be tricked. You go like, oh, but I did not see any clue of contact sports. No. It should not always be contact sports which will lead to splenic rupture. The splenic rupture can occur spontaneously. Doctors, please, can I move on now? So I'm just giving you ways that you can pick up things because, you know, it's not all, because I can just give you a simple question. 23-year-old male comes in with lightheadedness, fever and sore throat, and looks pale with left upper quadrant tenderness. No recent trauma, no recent contact sports. What's your diagnosis? Splenic rupture secondary to infectious mononucleosis. Boom. Then we are done. Okay? Good. Now, let's also talk about the rise of infectious mononucleosis. It has been popularly said that the rash occurs after the patient has infectious mononucleosis. The doctor did not test for infectious mononucleosis. The doctor went ahead to give amoxicillin because he was thinking about strep throat, right? And the patient develops rash. And, you know, if you work in healthcare, which I know a lot of you will be doing very soon, when you ace your exam, you realize that a lot of a lot of patients will come to the hospital and they will say, oh, I'm allergic to amoxicillin. I'm allergic to amoxicillin because when I got my throat infection and I was given amoxicillin, I developed a rash. Likely that the patient has real allergy to amoxicillin, or the patient had infectious mononucleosis, was given amoxicillin, and we know that infectious mononucleosis, you don't treat it with amoxicillin, and the patient developed a rash. This is how the rash of infectious mononucleosis looks like. However, amoxicillin is not the only antibiotic. So if you look at your question stem and you see various antibiotics, don't be fixated on penicillins alone. There are other medications which can lead to rash after a patient has been diagnosed with sore throat and was given antibiotics. So as I'm saying here, ampicillin and amoxicillin are the more common ones. But medications like azithromycin, levofloxacin, piperacillin tazobactam, that's a very strong antibiotic, and cephalexin, all these can also lead to this kind of rash. And also remember that the rash can also occur spontaneously on its own without even the patient taking any antibiotic. So I want to pause here. Can somebody tell me a little bit about splenomegaly in infectious mononucleosis and the issue of rash in infectious mononucleosis, please? Can you kindly raise up your hand and then let me know? And then just tell me quickly. Splenomegaly, give me a quick rundown. Splenomegaly in infectious mononucleosis and rash in infectious mononucleosis. And just address, should there be, okay, Dr. Sahar Mohammed, sorry.
Yeah. If the patient can complain of fever and malaise, fatigue, and sore throat, abdominal pain, and the hematocrit is low, maybe that indicated splenic rupture.
Okay. I have a question. Should the patient be engaged in sports or contact sports before the patient can develop the splenic rupture?
Not necessarily.
No.
Sorry, what did you say, Dr. Sahar? Should the patient be engaged in sports before they can get a splenic rupture? Dr. Kano says no. Okay, good. Now, can somebody tell me a little bit about rash and infectious mononucleosis? Dr. Frank, rash and infectious mononucleosis, please. Wash me.
Right. So, okay, a patient can come in. Maybe the patient has sore throats, and maybe the doctor just okay, patient has sore throat, and thought patient has just pharyngitis, and decided to give the patient antibiotics like amoxicillin or ampicillin, and the patient now develop rash. The person may think that is allergic to the antibiotic, but it may be that the patient had infectious mononucleosis before it was prescribed the antibiotic. So it can be as a result of the antibiotics, not necessarily that is reacting to the antibiotic.
Sure.
So,
yeah. And which other antibiotics can cause this kind of rash?
Okay. Levoflox, piperacillin tazobactam, and we have cephalexin.
Cephalexin, yeah.
Yeah.
Okay, good.
Azithromycin.
Okay, good. Now, another thing we need to learn when we are dealing with infectious mononucleosis are what are some neurologic complications of infectious mononucleosis. Number one, it can lead to Guillain-Barré. Facial and other cranial nerve palsies can be a complication. Meningoencephalitis can be a complication. Transverse myelitis can also be a complication. Aseptic meningitis can be a complication. Peripheral neuritis can be a complication. Optic neuritis, encephalomyelitis, and even Alice in Wonderland syndrome. And I don't want to get into all these conditions one by one, but Alice in Wonderland syndrome is rare. So as you are preparing for your exam, always remember, I'm going to focus on the more common things. So if I were you, I'll focus on Guillain-Barré, maybe transverse myelitis, facial and other cranial nerve palsies, and meningoencephalitis, right? But then you have to understand that. So when you see somebody with sore throat, Even in your clinical practice, don't just take it, oh, it's sore throat. No, that patient it could be the patient has infectious mononucleosis, and the patient can even go on to develop these complications. Okay, yeah. So other complications of Epstein-Barr virus infection, which leads to infectious mononucleosis, can be the hepatitis, cholestasis, pneumonia, pleural effusions, myocarditis, pancreatitis, acalculous cholecystitis, mesenteric adenitis. So like that is the intestines, right? The lymph nodes around there. Myositis, muscle inflammation, acute renal failure, glomerulonephritis, gastric pseudolymphoma, and genital ulcers. So Epstein-Barr virus can do so many things. That's what I'm trying to draw your attention to. Please pay attention to these things because we will quiz you after this class.